Okay, we'll go ahead and get started. Good morning and welcome to Medical Grand Rounds. I had mentioned last week at Grand Rounds that I was thinking of doing something educational on the COVID vaccine. I think we did that at a medical staff level the last couple of days, so we're going to stay away from that for now. I do have an open slot January 7th, so if there's new information to convey, that might be the date that we do this. Just very briefly, I do know numbers keep going up. At last count at Rochester General, there were about 200 admitted patients with COVID. The number of patients in the ICU, total number of patients was about 48. So they had increased their capacity to 4 teams and they were sort of working towards a 5th team today. So that's the status. We're not going to talk about COVID today. I'm very pleased to introduce Dr. Carolyn Zyloney. Dr. Zyloney went to medical school at SUNY Downstate in Brooklyn, and then did her neurology fellowship, followed by neurology residency, followed by a fellowship on headache at the University of Rochester. She's been a staff neurologist, mostly at Unity Hospital, since July of 2019. Since I know you all have a headache from listening to COVID presentations, we will be talking about migraine, a case of refractory pains. Without further ado, Dr. Zyloney.
Hello. So as you heard, I'm presenting on migraines. I did give a similar grand rounds at Unity about a year and a half ago, but I have updated it to include some of the new and emerging therapies that have come out. Okay, I'm just going to advance the first slide. Yes. So these are my objectives. I'd like to improve recognition of migraine, recognize and address medication overuse headaches, optimize lifestyle interventions, go over some guides for acute and preventive therapies of migraine, and discuss a little bit when you should consider a neurology or headache referral. So this is a patient that I've seen in the past. It's a 58-year-old female. She has a past medical history of depression, anxiety, hypertension, IBS, other chronic pains. So she's actually a fairly typical patient. A lot of patients with migraines have mood disorders, IBS, fibromyalgia, other chronic pain syndromes. Also, concussion's not uncommon since there's a link between concussions and headache. I have listed her current medications. She's on a triptan, rizatriptan, also known as Maxalt. She's on oral ketorolac, topiramate for prevention, amitriptyline mostly for sleep, and duloxetine for mood, and verapamil for hypertension. She has tried gabapentin and valproic acid in the past without tolerating it. She denied a family history of headache, and she is on disability from her other chronic pains, partially also her headaches. She's not a smoker, lives with her husband. So she came to me saying she had had migraines since her 20s. They got worse over time. When I saw her, she was having 3 or 4 severe migraines per week. She felt it was a little bit over half the month that she was getting them, and they were over the right temple. They were throbbing and sharp. She denied any sort of aura, like no visual aura, but she did have photophobia and nausea. She denied autonomic features, which I ask about, particularly with unilateral headaches, just to rule out a trigeminal autonomic cephalgia, but she denied that. She prefers to lay down during a migraine. She feels worse with bending over, which is fairly common for people to feel worse with really a lot of any activity or movement. And she told me that rizatriptan gave her partial relief, but caused her to feel hung over. So she didn't like the side effects. She had tried a couple other things in the past, 2 other triptans, sumatriptan, naratriptan. They either stopped working or never helped. Excedrin migraine had not helped her. She'd never been on an antiemetic despite the fact that she has nausea. And she reported prior trials of venlafaxine, and as well as I'd mentioned, the verapamil, amitriptyline, and topiramate that she was on. And then the valproic acid caused altered mental status, and the gabapentin caused muscle spasms, so that those were her side effects. So on exam, she was obese, but well appearing. She had full range of motion at the neck. I palpated her head and neck, and there was no tenderness to palpation in the head. She did have a little bit of tenderness in the posterior neck. She had a normal mental status, wake alert, normal speech. Cranial nerves, I did a fundoscopic exam, and her optic discs appeared normal, no papilledema. Her visual acuity was on a near card, pretty good, like J1, J2. Her visual fields were full, pupils equal reactive. She had no facial weakness, intact sensation. So basically normal cranial nerves. She also had full strength, normal tone, intact sensation in the arms and legs, no ataxia, normal reflexes, and a normal gait. So overall, her exam was pretty much normal except for the mild tenderness in the neck. We did an MRI of her brain, and this is what it looked like. She had a couple of these little T2 flare hyperintensities in her brain, which we thought was either small vessel disease or related to her migraines. So just to switch off from the case and talk about diagnoses. So when patients like her present with a headache, these are the diagnoses I consider. Migraine is always up there because it's very common. Tension headache, also very common, but typically less disabling. And then there's a few other less common headache disorders that I think about. Idiopathic intracranial hypertension, also known as pseudotumor cerebri. Trigeminal autonomic cephalgias, which include cluster headaches, cervicogenic headache, and then other secondary headache disorders. So when I'm seeing a patient, I obtain their history, and I'm looking for clues in the history to either point to or exclude a secondary headache disorder. Also, the exam helps with that. Sometimes you could use a screening tool such as the ID Migraine, which can help identify patients with migraine. It's like a 3-question tool, or you can use criteria from the Headache Society. So the ICHD-3 has criteria for every headache disorder. Now, if the history and screening tools indicate a probable migraine, I usually will consider that the diagnosis. If that is not consistent with their history, then I have to go back and think about it more. So I assess their level of disability, the impact of their headache. If it's relatively low level of disability, then you can think about something like a tension headache. If it's a high level of disability, then I usually need to get more information. That can include a headache diary, trials of treatments that are helpful for certain conditions. It may include imaging depending on the patient, and obtaining any additional information that would help to consider other types of headaches. And if you're primary care and you do this and you still can't figure it out, you can refer to a headache specialist. So just to go over migraine in a little bit more detail, it's very common. 36 million people in the US over age 12 have migraine. About 18% of women, 6% of men, and 10% of children. Nearly 1 in 4 households has at least one person in it with migraine. Migraine is pretty common in sort of the middle of life between ages 25 to 55, but I've seen it in young children and in people in their 80s, 90s. 4 million people, or about 1 to 2% of the population, have chronic migraine, and 10 to 20% have aura. And because of how common it is, the majority of migraine management is done by primary care physicians instead of neurologists. And migraine has a big impact on patients. It's the 7th most disabling illness overall, according to the WHO burden of disease. It causes $36 billion of healthcare costs and lost productivity costs. It causes 10+ million physician office visits. 4% of ER visits are for headache, and of those, we think a third are migraines. 81,000 inpatient stays for headache. Patients with migraine do tend to miss work about 4 days per year on average. And even when patients go to work, 62% of them feel that they have a reduced, reduced productivity of about a quarter. So this is the WHO Global Burden of Disease from 2015, and you'll see here for ages 24 to 44, migraine is either ranked 3rd or 4th. Migraine is also ranked for younger patients. It's 5th for under 20, 19-year-olds, 6th for people over 45, but it's causing a big burden of disability right behind neck pain and depression. And there's a lot of indirect costs. So this is data from a survey that was done as part of a study where people felt they were missing out on work opportunities, that it was impacting their career to have migraines, that they maybe were making less money, they were less productive at work, they felt stressed out because of the fact that their migraines were not predictable. They felt it impacted them at home, that they couldn't interact with their kids as much, couldn't take care of their family as much. They felt helpless when they had a migraine. And they would like better care. So migraine clearly has a big impact on people's lives. These are the criteria for migraine adapted from the International Classification of Headache Disorders, 3rd edition. So you have to have at least 5 attacks fulfilling the below criteria. The headache attack should last 4 to 72 hours if untreated or unsuccessfully treated, but it can be shorter with appropriate treatment. Also in children, it's often shorter. And headaches should have at least 2 of the 4 characteristics: unilateral, pulsating, moderate or severe, and aggravated by physical activity, and at least 1 of the following: nausea or vomiting, or photophobia and phonophobia. So I like to remember this pound. It helps me remember that headaches are usually pulsatile. At onset, it's usually 4 to 72 hours. It's usually unilateral, but can be bilateral. And there's usually nausea, and it's usually disabling. So I had mentioned the ID Migraine Tool. It's a 3-question tool that you could ask in a primary care office to try to diagnose migraine. You asked, in the last 3 months, did you have any of the following with the migraine: nausea or sick to the stomach, lights bothering you, limiting ability to work or do other activities? And if people say yes to at least 2, there's a high likelihood that they have migraines. This is 81% sensitive, 75% specific, and has a positive predictive value of 93%. So it's a pretty useful short tool. This is just to go over some of the symptoms that can come with migraines, particularly the aura. Auras are typically fully reversible, last between 5 to 60 minutes, usually comes on gradually in a spreading pattern. The most common one is visual. You could have positive symptoms like flickering lights, spots, lines, scotomas, prisms, kaleidoscopes. You could have sensory symptoms like numbness, tingling. Motor symptoms are less common, but you would think of like hemiplegic migraines where they're weak on one side, it can mimic a stroke. And then aphasia, difficulty with language, is another aura. This is just a typical time course of a migraine. A lot of people report that before the actual headache starts, they get this sort of premonitory symptom. They might have mood changes, fatigue, cognitive changes, food cravings. And then sometimes there's an aura. If people are prone to aura, they can get that aura right before the headache or even into the headache. And then the headache usually will start, it'll peak, and then it will resolve. But after the headache, a lot of people report a post-drome where they have either fatigue, cognitive changes, muscle pains. So the headache itself is not the only thing that causes the disability. The premonitory and post-dromal and aura symptoms can cause disability as well. This is a survey that was done of the prevalence of common symptoms during a migraine. Headache, pain was the most common, but not 100% of people actually have pain. You can have a migraine without head pain. Nausea came second, vision issues third, vomiting fourth, and then there was a variety of other things like neck pain, eye pain, dizziness, photophobia. So just to mention chronic migraine, I talked about that before. The definition of chronic migraine is headaches on 15 or more days a month for 3 months, and they should be consistent with migraine on at least 8 of those days. And just another caveat to keep in mind is that if the headache is daily from the onset, you might want to consider new daily persistent headache. as a potential diagnosis, but it can mimic chronic migraine because some patients with chronic migraine actually have daily headaches as well. So I also had mentioned that I got an MRI for my patient. This is a guideline for imaging and migraine. So the American Academy of Neurology recommends that you do not image patients with a headache exam consistent with a primary headache disorder and a normal neurologic exam. But if you do get the imaging, an MRI may be either normal or show these two T2 flare hyperintensities, which sometimes you might think are MS or small vessel ischemic disease, but they tend to be small. They're usually not periventricular, so that can help you distinguish between MS. So let's talk about the pathophysiology of migraine. There's a couple theories. One is the theory of cortical spreading depression, where there's this wave of depolarization, usually from the back to the front. There's also the theory of trigeminal vascular activation or inflammation, where there might be inflammation in the dural vascular structures that are connected to the trigeminal nerve via ganglion, or in the neck connected to the cervical dorsal root ganglion. And that goes to the trigeminal cervical complex in the brainstem, and that signals all the way up to the hypothalamus, thalamus, and cortex. So here's just another look at the trigeminal vascular activation theory. So you can get extravasation of substances like substance P and endothelin, CGRP, BIP, somatostatin from around the vasculature. And then there's the trigeminal nerve, which gets sensitized peripherally, and that interacts with the brainstem. And then when it interacts with the brainstem, you get central sensitization, which can lead to more chronic pain. And that can also trigger cortical spreading depression, and that also causes the headache pain. There is a genetic link. Half of the liability of migraines is usually due to genetics. 70% of people with migraines have a family history. If you have a first-degree relative with a migraine, you have a twofold risk of getting it. And migraine with aura seems to have a higher genetic link than without aura. Here's some genes that have been identified, but many of them sort of are weaker links. Usually there's many genes involved. There are a couple key genes to know. There's the CACNA, the ATP1A2, and the SEN1A. These are involved in familial hemiplegic migraine. So let's talk about triggers. 75% of people report at least one trigger, but the tricky thing is the premonitory symptoms can sometimes be confused with the trigger. So if someone craves chocolate and eats chocolate as part of their premonitory symptom, they might think the chocolate caused the headache. Here's a survey of common triggers that were reported. Stress was the most common, but hormones, think like menstrual migraines is also common, skipping meals, weather, sleep disturbance, certain odors, lights, alcohol, smoke, certain foods, exercise, and sexual activity have been reported as triggers. So just to review some dietary triggers, there can be some benefit to an elimination diet to try to identify a trigger. Common triggers include MSG, sometimes dairy, chocolate, fatty foods, aged cheese, red wine, beer, champagne, things with a lot of nitrites. Caffeine, overuse, or withdrawal can also cause headaches. So let's talk a little bit about treatment. I had mentioned there's acute treatments and also preventive treatments, but underlying that all is lifestyle. So for everyone, I always get an idea of if there's any lifestyle issues like poor sleep, mood disorders or untreated stress, skipping meals, dehydration, and I address those things and I talk about headache triggers. So for acute treatment, there's NSAIDs, acetaminophen, combined analgesics containing caffeine, think about Excedrin for that, triptans, DHE, antiemetics, nerve blocks, neurostimulators can be used acutely, and then the new ones are ditans and GPAPs. For preventive treatment, there's antidepressants, tricyclics, and SNRIs in particular. SSRIs don't seem to be as helpful. Antiepileptics, topiramate, zonisamide, valproic acid, antihypertensives like propranolol, verapamil, candesartan, certain vitamins like magnesium, riboflavin, CoQ10, neuromodulators as well, like the neurostimulators, that includes the Cephally device, Botox, and CGRP monoclonal antibodies. So just to review the lifestyle a bit more, I tell people to reduce caffeine to less than 8 ounces before noon, maintain a regular sleep schedule, improve sleep hygiene, avoid food triggers, avoid fasting, eating sort of a healthy, well-balanced diet, getting at least 48 ounces of water, and trying to exercise regularly. So just to go over the migraine acute medications, your mainstay is going to be the over-the-counter stuff. Most people have tried these already. Then antiemetics and triptans are usually in there, and then usually GPAPs and ditans are for people who either can't get triptans or don't tolerate them. And then there's DHE, which I sort of think of as more like a rescue treatment. 40% of patients are dissatisfied with their acute treatment, and only 22% use a migraine-specific medication. So a lot of people who have migraines are really not adequately treating them. And about a quarter of migraine patients use barbiturates or opioids, which has some issues, mostly due to medication overuse, headaches. And a lot of the reasons that people have suboptimal treatment is they're not using their migraine-specific medications, or they are, but they're on too low of a dose, or they're waiting to take it. These are most effective if taken early, or they take it, it doesn't work, and then they're not repeating it. I do tell people to repeat their triptan in 2 hours if they don't have relief. Or the route of administration, maybe they're taking an oral pill, but they have a lot of nausea and gastroparesis and they're not absorbing it. Or if they have a headache that goes from like 0 to max within minutes, they need something that's going to be faster. So optimal use is using as early as possible, using migraine-specific medications as part of the plan, restricting use of abortives to 2 to 3 days a week due to risk of medication overuse, co-prescribing antiemetics if they have nausea or vomiting, having expectations and goals and monitoring their response to the treatment, and treating 2 or 3 attacks before they judge if the medication worked. So NSAIDs and simple analgesics are the mainstay. They are actually pretty effective. They are only slightly less effective than triptans in studies. 30 to 50% of patients report headache freedom at 2 hours versus 10 to 20% with placebo. And higher doses of NSAIDs can be more effective. For example, ibuprofen 400 is better than 200 or even 600 or 800 for some people. Triptans, they do have slightly better effectiveness compared to NSAIDs and other over-the-counter medications. 40 to 70% of patients have relief at 2 hours versus a third with placebo. So more patients responded to the triptans. Long-acting triptans may be less effective at the 2-hour mark, but they may be better for certain types of headache like menstrual migraine where people are at risk for 5 days. And patients who tend to get allodynia, like sensitivity to touch during their migraines, typically don't respond as well to triptans once the allodynia sets in. So that's why they have to treat it early to get the best success. Now, triptans do have some contraindications. So triptans work on the 5-HT, 1B, 1D, and perhaps the 1F receptor, which works at the trigeminal nerve to reduce neurogenic inflammation, but also causes vasoconstriction. So patients with coronary artery disease, history of stroke, coronary vasospasm, uncontrolled hypertension really shouldn't take it. Also, there is an interaction with MAO inhibitors. So usually if someone's on an MAO inhibitor, you avoid triptans, but fortunately the MAO inhibitors are not very commonly used anymore. You also should not combine within 24 hours of DHE or ergots. Now, there is a relative contraindication for hemiplegic migraine and brainstem aura. I think not everyone agrees with that, but theoretically they were afraid that these patients may be more prone to the vasoconstrictive effects of the triptans, although I will still sometimes use it in these patients. And then pregnancy is a relative contraindication. Some post-marketing data has come out showing that triptans do seem to be safe if used in pregnancy. But I think most OBs don't want to risk it. There is no evidence that triptans, when taken combined with SSRIs or tricyclics, cause serotonin syndrome. That's a theoretical risk, but there don't really seem to be cases of this. Here's a list of triptans. There's a lot of different triptans. Probably the most common one is sumatriptan or Imitrex. It comes in 25, 50, and 100 milligram tablets. I find the 25 is not very effective, so I usually start with the 50 or the 100. It also comes in an injection, a 4 or a 6 milligram injection, or a nasal spray. And it's actually quite affordable, particularly the oral version, $16 for 9 tablets, whereas the nasal spray and the injection can be quite expensive. Rizatriptan comes in 5 and 10 milligram tablets or oral disintegrating tablets. It's got about the same half-life as sumatriptan, about 2-ish hours or 3 hours, and it's also quite affordable. There's a couple of other triptans. So zolmitriptan also comes in an oral disintegrating tablet and a nasal spray, about the same half-life. It is a little more expensive. And then there's almotriptan, which is actually the best tolerated one of all the triptans. Again, a little more expensive. Elatriptan has the lowest recurrence rate, also a little more expensive. Frova is a long-acting one. It's got a 26-hour half-life. So it's actually mainly used for prevention of menstrual migraine. And it's also quite expensive. Niratriptan has like a medium half-life. It's about 6 hours. And it's relatively affordable. So niratriptan can be used either for acute treatment or prevention of menstrual migraines. So I had mentioned that there were some new and emerging treatments that I wanted to discuss. So one of them is the class of medications known as GPAPs. So these came out about a year ago. They're small molecule CGRP antagonists. They're not monoclonal antibodies. And right now there's 2 on the market, ubrogepant, which is known as Ubrelvy, and rimagepant, which is known as Nurtec, that's the dissolving tablet. And the major benefit is that they lack cardiovascular risk factors. They don't seem to cause the vasoconstriction. Another benefit is they have relatively few side effects. So I think for Nurtec, 4% of people reported nausea. There was some fatigue with Ubrelvy, but usually I think overall they're better tolerated for most people than the triptans. But there are some medication interactions. For example, with verapamil, it may be less effective. It does interact with like antifungals, antibiotics, phenytoin, HIV meds. So before you prescribe it, you just want to double check the medication interactions. And it has a lower risk of medication overuse. I believe there are some clinical trials showing in trials to see if these are effective for prevention rather than acute treatment, but the acute treatment clinical trials did come out positive. So it is available on the market as an acute treatment. We don't know yet if it will be available as a preventive in the future. So I typically will consider these for patients who either have contraindications to triptans or have failed at least 2 or 3 triptans due to either side effects or lack of efficacy. Now it is kind of expensive. There's no generic since it's new. 8 tablets is about $800 without insurance. So you may have heard of the monoclonal CGRP antibodies. That's like Aimovig, Ajovy, and Emgality. The GPAPs are different. They're smaller. They're oral, whereas the monoclonals are injections. They're used for acute treatment, whereas the monoclonals are preventives. They work within hours, and they have about an 8 to 12-hour half-life, whereas the monoclonals stay in the body for weeks. Now, the other new medication that came out is ditans, and there's only one on the market, lasmiditan, also known as Reviao. It's 5-HT1F selective, so that tends to mean that you don't get the vasoconstrictive side effects because the vasoconstriction was more from the 5-HT1B and D. It has fewer side effects than, so it has the less side effects of vasoconstriction, so it's safe to use in patients with cardiovascular disease. It does have a high CNS penetrance, so a lot of people do report dizziness and drowsiness. And as a result, the FDA is recommending that patients do not drive for 8 hours after each dose. It comes in 3 doses and it's fairly expensive, about $640 for 8 tablets. So usually for an acute treatment plan, I'll give a combination of things. I'll give a sumatriptan or another triptan with an NSAID like ibuprofen, and if they have nausea, I'll give an antiemetic. Now, just keep in mind, there's no data to support the efficacy or safety of one triptan over another. So usually selection is based on other factors like cost, duration of action, side effects. There is some evidence that a stratified treatment plan is the best. So for example, if some patients have very mild headaches, maybe just an NSAID is fine, but if they have a more severe headache, they may want to go to the combination of the sumatriptan with the triptan with the NSAID with the antiemetic at the symptom onset. So you may want to consider different treatment plans if people are reporting sort of 2 or 3 different headache types. What not to use. So I had mentioned barbiturates, like butalbital containing medications. Those include Furoset, and then opioids that I usually try to avoid because they're linked to medication overuse. So just 10 doses per month of either of these can cause medication overuse. Triptans and NSAIDs also can, but usually at higher quantities. So medication overuse headache is defined as headaches occurring 15 or more days per month in a patient with a pre-existing headache disorder who has been regularly overusing those acute meds for 3 months. So just 10 or more days of ergots or triptans or combination analgesics or narcotics, or 15 or more days of simple analgesics can do this. And if you stop the medication that's overused, they may improve. So that's usually worth talking to people about taking a holiday from whatever medication like ibuprofen if they're overusing it. I'm going to move on to preventive therapies, when to start it. So I usually will start it if there's 4 or more migraine days per month or 6 or more headache days per month if people have a mix of migraine and non-migraine headaches. And also why you start it. So if you don't start it, episodic migraine can progress to chronic migraine at a rate of 2.5% per year. And if you intervene with a preventive therapy, you may reduce that progression to chronic migraine. And the goals of treatment is a 50% reduction in either attack frequency or intensity, or an improved response to the acute medications. Now, I do make some exceptions. So there are people who maybe have less than 4 attacks a month, but their attacks are extremely disabling. For example, hemiplegic migraines that cause people to go to the ER. So some of those patients you may want to treat even if they don't have 4 migraine days a month. Now, to talk about patients' ideas of preventive therapy, about half of patients would benefit, but only a quarter of them are actually on a preventive medication. And a lot of patients have difficulty with preventive medications. They have difficulty with adherence, either due to side effects or the burden of taking a daily medication. So only about 15 to 30% of patients are actually taking it as they're supposed to. Now, the choice of agent depends on the patient's comorbidities, side effects, patient preference, and I usually will recommend that patients try 2 or more oral preventive therapies before considering Botox or a CGRP monoclonal antibody. But I do find that a lot of patients have resistance to preventive medications, either because of fear of side effects or they don't like the idea of taking a daily medication. Some of these preventive therapies are even twice a day or 3 times a day. And then also a lot of patients express a preference for non-pharmacological or natural treatments. Here's a list of preventive treatments. There's several beta blockers. They have level A evidence. Topiramate also has good evidence. Amitriptyline, pretty good evidence. A couple other beta blockers. Divalproex does have good evidence, but a fairly large amount of side effects. Venlafaxine, level B evidence. Tenolol, gabapentin, really we don't have as much evidence for. Candesartan, some evidence. Same thing for lisinopril. Verapamil, we don't really have a ton of evidence for, but we do still sometimes use it. Botox has good evidence. CoQ10 is a supplement. There's some evidence for it, but not strong. Magnesium, riboflavin, and feverfew also have evidence. So let's take a moment and talk about Botox. It's approved only for chronic migraines. So these are patients with 15 or more headache days per month for 3 months. The initial dosing is 31 injections in the frontalis, procerus, corrugators, temporalis, occipitalis, cervical paraspinals, and trapezius muscles. And it's a total of 155 units, and it's given every 12 weeks. But you can increase the dose up to 195 units using the follow the pain method. So you inject more where people have more pain. And the theory behind how it works is basically this is a nerve and this is a muscle. This is the neuromuscular junction. The Botox blocks the release of acetylcholine into the junction. So this can relax the muscles, but it also seems to reduce signaling back through the nerve, and reducing that signal from the nerve into the trigeminal nucleus seems to block the trigeminal vascular activation. This is data from the clinical trial for Botox, the Preempt study, that showed that people getting Botox had improved response compared to placebo. There was some response at 4 weeks that was statistically significant, but as people stayed on for 24 weeks, there was a bigger difference. So at 24 weeks, there were 9 fewer headache days per month with Botox versus 6 fewer with placebo. And Botox in general results in significant improvements. There were 50 and 75% response rates at week 24. So people had reported with Botox, that's the blue bar, about 47 to 48% improvement in headache and migraine days compared to 35-ish% with placebo. And that was a 50% response, 75% responders. There were about 25% who had a 75% response versus 15% with placebo. So it seems like about half of people have at least a 50% response. And then there's a number that have a 75% response to the Botox. And another thing to keep in mind is usually you want to encourage people to do at least 3 rounds of Botox. I mentioned about 50% respond with the first treatment, but then with the second treatment, an additional 10 to 13% respond, and with the third, an additional 10 or 8% respond. So if you stick out through 3 treatments, about 70-ish% of people are responders, at least 50% responders. And people also report reduced disability. One measure of disability is the HIT-6 questionnaire. So people are reporting less disability based on this questionnaire. The other new treatment is CGRP monoclonal antibodies. There's 4 out now. Arenumab, which is known as Aimovig, fremanezumab, which is Ajovy, and galcanezumab, which is Emgality, have been out for about 2 years. And earlier this year, eftanezumab, which is Vyepti, and infusion was also approved. The arenumab is available in 70 or 140 milligrams every 30 days. It's a subcutaneous injection, usually given at home. Fremanezumab is available either as a 225 milligram subcutaneous monthly or a 675 quarterly injection. Galcanezumab has a loading dose of 240 milligrams subcutaneously and then 120 milligrams every month. And eftanezumab is a 100 milligram IV infusion, also given every month in an infusion center. So this is what one of the auto-injector pens looks like for one of the medications. And the theory on how it works is that the CGRP monoclonal antibody either binds to the CGRP ligand or receptor and blocks CGRP, and CGRP is involved in that trigeminal vascular activation and inflammation pathway. So these seem to be pretty effective. This is data from the arenumab clinical trial, but the other medications have fairly similar efficacy data. About 50% of people on the 140 milligram dose were 50% responders. So about half of people getting the 140 milligram dose had a 50% reduction in their headaches. So for the 70 and 140 milligram doses, there were about a little more than 3 fewer headache days per month compared to 1.8 fewer headache days per month with placebo. And there was improvement noted after the first month of treatment. And as people continued on the treatment for up to 6 months, there was increased improvement. So back to the original patient I discussed, she tried Botox, it did not work. She tried arenumab, she had about a 50% reduction in her migraines on arenumab, but she was still having 6 to 8 severe migraines per month. She had an incomplete relief from the Triptans, so ubrogepant was trialed. She had a similar amount of relief from this, but she reported fewer side effects, which was a benefit to her. So just to go over when to consider referral to a neurologist or headache specialist, if patients have a red flag presentation with their headache. So think, I like to think of the word SNOOP for that. So that means that there's symptom onset at an older age, or if there's atypical features with it, for example, like weakness, prolonged auras, unilateral headache, people with comorbidities that are concerning, like a history of cancer, people who have a change in the characteristic of their headaches. For example, they used to have one type of headache, now they're getting a totally different type of headache, or people with an abnormal neurologic exam. Chronic migraine, which is 15 or more headache days per month, usually requires treatment with a headache specialist. And then also if they have high frequency episodic migraine, like 10 to 14 days per month, and they've tried a couple of treatments and they haven't worked, then you might want to consider a headache specialist. And then also if they have medication overuse headache. So I had mentioned the SNOOP to help identify life-threatening headaches. So that means systemic signs and disorders accompanying neurological symptoms. That's the N. O is onset new or changed, or onset is thunderclap in presentation, meaning it's like maximal intensity at the onset. Or there's, for P, papilledema, pulsatile tinnitus, positional features, or it's precipitated by exercise. SNOOP. So here's some pearls. Consider migraine as a diagnosis in people presenting with headaches because it is common. Treating medication overuse is necessary, but oftentimes it's not going to be sufficient to completely resolve their headaches. Patients, lifestyle counseling, and adequate medication trials are key. Encourage people to stick with the medication, not to give it up too early, to try an adequate dose. Don't be afraid of triptans. You could start with either the 50 or the 100 or the sumatriptan, not the 25. And remember to treat the accompanying nausea. So these are a list of my references. I mentioned the ICHD-3 that has all the classification criteria for the different headache disorders. The AAFP also published some guidelines. And then there's a couple of other articles. The AAN also has guidelines for headache treatment, and the American Headache Society released a recent position statement with treatment guidelines. All right. So that concludes my presentation. I'm happy to take questions if there are questions. I think you're muted.
Seeing a couple of comments congratulating you for a well-done review. How many neurologists are in your headache specialty group?
I'm the only certified headache specialist at either Unity or RGH at the present moment. But over at Unity Neurology, we do have, I believe, 6 outpatient neurologists at the present time. Yeah. RGH, I think, recently hired a couple, so I believe there's about 4. Maybe one of the neurologists at RGH can clarify that, but I believe there's about 4 at RGH. And we also recently hired someone at UMMC Leroy, so we have a neurologist there as well.
So Dr. Chaudhary asks, if a patient has visual aura without a headache, what do you advise?
So the first thing is the aura. Well, first I try to figure out if it's a typical migraine aura, if it has this sort of scintillating scotoma quality. If not, I do usually advise an eye exam to make sure that they don't have a retinal detachment or some other reason that they're getting what they think is an aura. The second thing I do is I assess how bothersome the aura is, how frequent it is, if it really impairs their vision. There are a couple of medications I use, so I might use one of the migraine preventive medications if they're getting a lot of visual aura. I also sometimes use lamotrigine at a very low dose to treat auras, but it really comes down to the patient if they want to treat the auras or not.
Yeah. Does magnesium or vitamin B2 work?
Yes. Both of those are helpful. I had a slide earlier that had the list of medications that are helpful, and both magnesium and riboflavin, which is B2, are listed as level B evidence. There's also a couple other vitamins, CoQ10, feverfew, butterbur, that have some evidence. People have to take them every day. The recommended dose of magnesium is about 400 to 600 milligrams. The riboflavin is also 400 milligrams. So I often do recommend these vitamins for people who either are concerned about the side effects of prescription medications or prefer a natural approach.
Do you find, this is from Ann Ford Fricky, do you find changing birth control changes the headaches?
So in general, when patients have migraine with aura, I do try to recommend that they either not use or stop estrogen-containing birth controls because those can sometimes worsen headaches. I also try to get a bit more history, like did their headaches change when they started the birth control, or are they getting mostly menstrual migraines? Sometimes people with prominent menstrual migraines, they may benefit from a birth control method to reduce the number of menstruations they get, for example, like a continuous birth control or an IUD.
So another question that popped up here, Dr. Hamza Malik says, I saw a study in the Annals of Neurology where rats given CGRP antagonists had strokes induced. I assume this is because they inhibit vasodilatation, which might prevent some brain tissue from dying. Should we be hesitant to give these medications to people with atherosclerotic disease?
So the companies that make the CGRP antibodies actually have investigated this. There were some animal studies, like the study he's referring to, that showed these adverse effects, but I believe those rats were given extremely high doses, much higher than what a human would receive. There was a study done in humans looking at EKG changes on a treadmill, and I believe these were patients with known CAD and who were given a CGRP antibody, and they did not have any EKG changes during exercise. So a couple of the studies that have been done in humans have shown that they do not seem to cause vasoconstriction or ischemic heart disease in humans. So in general, I have been okay with using it in patients with CAD, but I know some headache specialists are a little hesitant. They might prefer to do Botox or another oral agent in those patients with CAD.
And then his other question was, how do you approach pregnant patients with severe migraine?
So some patients have actually an improvement in their headaches during pregnancy. About a third get better. A small number get worse and some stay the same. So it might be that when a patient becomes pregnant, they don't actually need their preventive medication anymore because they improve. But for patients who don't improve, many of the medications listed are not recommended or not safe in pregnancy. Definitely want to avoid divalproex sodium in anyone of childbearing age. Usually the topiramate, I request that they be on a birth control method if they're on that. For other agents like amitriptyline or propranolol, I'm usually okay with people taking it up until they become pregnant, but I will stop it if they become pregnant. There's some data that cyproheptadine, which is periactin, and memantine, Namenda, are safe in pregnancy. So if the OB-GYN is okay with it, I'll usually use those for prevention. Another thing I often use is nerve blocks with lidocaine because those seem to be safe in pregnancy. It's a local treatment. I do the injections usually in the occipital nerve, sometimes in the auriculotemporal and supraorbital nerve. And those sometimes can work really well for pregnant patients who want to avoid any medication. For acute treatments, if the OB-GYN is okay with rare use of triptans, I would usually allow that. But if the patient or the OB-GYN prefers to avoid triptans, then I usually recommend acetaminophen. There's certain antiemetics that are also safe. There's some data that magnesium at high doses can cause bone issues for the fetus, but most OBs are okay with magnesium during pregnancy.
So Dr. Jackson asked, what percentage do not improve with age?
I would have to go back to the primary literature. It seems like most people get better after menopause, but during the perimenopausal period, you can have worsening. I don't know the exact percentage that doesn't improve after menopause, but I know anecdotally in my practice, I have a number of older patients who've had headaches most of their life.
All right, looks like we're pretty much at the end of our questions and close to the end of the hour. So there will be no medical grand rounds next week. It's Christmas Eve. For everybody, have a happy holiday season and Happy New Year. I think 2020 for most is going to be a year to be quickly forgotten, hopefully. And hope you all have a great 2021. And see you next year. Thank you very much for a very nice review on migraine.
It was my pleasure.
I am recording this. I'm going to stop the recording now.